Hello, everybody. Today we're going to be talking a little bit about ADHD and the pharmacological treatments for ADHD. So, first, getting into prevalence. As many of you know, ADHD is quite prevalent, and diagnoses are becoming more and more prevalent. And it's not really clear if it's that the prevalence is actually increasing or if we're getting better at identifying ADHD. But regardless, the prevalence is quite high, about 6 to 10% of individuals, and there has been an increase in recent years of ADHD diagnoses. Now, overall, we see that ADHD is far more prevalent in males than females, with in a normal typical sample, there being about 3 men with ADHD for every 1 woman with ADHD. In clinical samples, this tended to be a wider range, so 3 to 1 to 9 to 1. It's a big deal as far as why children are referred to mental health clinics. About half of all referrals are due to ADHD-related problems. So this is one of the primary issues we see in childhood. And as you can see, it has a huge societal cost, estimated to be somewhere between $36 and $52 billion, or between $12,000 and $17,000 per individual. So a very significant disorder. One of the things that I thought was really interesting is this graph here. And I think this is important to show because it talks about the importance of doing a really thorough evaluation for a diagnosis of ADHD. So what this is this is a Canadian study that looks at separated boys, girls, and all children, the percent of children receiving treatment for ADHD. And what we see is that it sure looks like there are fewer children receiving treatment if they're born in January than if they're born in December. So why would this be? Why would it be that there's this upward trend throughout the year that the later your birthday is, the higher the likelihood of receiving treatment for ADHD? Well, what this is in Canada, the cutoff for internet grade is December 31st. So children who are born in December are the youngest in that grade. So what this is telling you is that we have an issue with our diagnosing. Because there's no reason to think that children born in December would be more likely than children born in January to have ADHD. So what this is telling us is children born in December are younger and likely have more behavioral problems and are more likely to therefore be probably misdiagnosed as having ADHD. So again, it really shows that there's some error in the system as far as our diagnosing. So what is ADHD? Is it a medical disorder? Is it a behavioral disorder? Or is it just really related to the school environment? Is it just kids having trouble adapting to school? Or is it possibly an interaction between environment and genes? And the answer is kind of all of the above. So speaking biologically, in ADHD, what we see is an altercation in the dopaminergic activity in the prefrontal cortex. So dopaminergic, again, meaning dopamine. So we see too little dopamine activity in the prefrontal cortex. So why is this important? Well, the prefrontal cortex is important for regulatory behaviors. So, attention, cognition, maintaining those. Also not interrupting, not being able to inhibit. All those are going to be mediated by the prefrontal cortex. So if you don't have adequate activation of the prefrontal cortex, all of those abilities are going to be limited. So with this, if you actually have lesions to the prefrontal cortex, the symptoms you see are distractibility, forgetfulness, impulsivity, poor planning, all the things you see in ADHD. So the thought is that prefrontal cortex seems to be very important in ADHD, and in particular, there are two neurotransmitters that really seem to be important, and those are norepinephrine and dopamine. So with this, it's not likely surprising that the treatments that we use for ADHD, especially the stimulants, tend to increase levels of dopamine or norepinephrine. So it fits with the whole theory of we have inadequate levels of dopamine or of norepinephrine, so these medications help by increasing that. So one of the things we have to consider, though, is dopamine and the nucleus accumbens. So as we've talked about before in previous lectures, nucleus accumbens is a major area for reward and reinforcement in the brain, and also for addiction and abuse potential. So anytime you have a medication that leads to more dopamine being released in the nucleus accumbens, there's always that threat of abuse. And with this, stimulants do have this, where you do see dopamine changes in the nucleus accumbens, and this is likely why there is some potential for abuse in these medications. So going back to ADHD, we do find that it's highly heritable. So there's definitely a genetic component. Now with this, there does seem to be an interaction with the environment. So it's not uncommon for children to do fine in an environment that isn't overly taxing or challenging, but then to show the symptoms once they're in a more challenging, difficult environment that really forces them to focus or to stretch their legs and do harder work than they've done previously. We've already talked a little bit about prefrontal cortex and dysfunction of the prefrontal lobes. We have more slides on that, so I won't get into that. So we mentioned the theory that ADHD may be especially associated with a lack of dopamine. And in particular, the dopamine transmitter DAT1 gene has been implicated as the possible explanation for this genetic heritable link. Also, the DRD4 dopamine receptor gene has also been implicated. So the thought is that this may be explaining that gene versus environment interaction, where you have this vulnerability, but it's not going to actually manifest. You're not actually going to see it unless you're in an environment that is challenging enough to exploit the vulnerability, essentially. There are some differences in a couple different areas of the brain. We'll talk about that in coming slides. And you do see abnormal brain activation during attention and inhibition tasks with ADHD. So looking at some of the brain studies, what we find is that the frontostriatal region of the brain in ADHD and the pathways connecting this region with the limbic system via the striatum and the cerebellum are really important for understanding ADHD. So these areas of the brain are associated with executive functioning abilities. So attention, spatial working memory is one of the big things that you see with ADHD being impaired, and also some short-term memory. Children with ADHD have smaller right prefrontal cortex, have a smaller right prefrontal cortex. They also have some structural abnormalities in the basal ganglia, especially the caudate nucleus, smaller total right cerebral volume, smaller cerebellum, and they also show a delay in the brain maturation. In particular, and I think this piece is really important, in children with ADHD, you see a lag of 2 to 3 years behind children without ADHD in the development of the prefrontal cortex. So again, we already discussed the importance of the prefrontal cortex and inhibition and attention. So you can imagine if you're 2 to 3 years behind in your development of this, you're going to look different than your peers. You may be in fourth grade, but that part of your brain's working at a second grade level, and you're just not able to perform in the same way. So what are some of the deficits we see? So obviously difficulty with attention, which what attention is it's really the ability to focus on or filter information. So it's either focusing on important information or filtering out unimportant information. So someone with ADHD may have it where they're able to focus on something, but it's very easy for them to be drawn to other things and to, not be able to stick with just focusing on one thing. With memory, it's the ability to hold information in your mind. So, especially with spatial things, it's your ability to remember how things are ordered in space relative to one another. So with this, individuals with ADHD often have trouble with any activities that require a visual spatial sketch pad, oriented in space, trying to find things geographically, often very difficult. Set shifting. So what set shifting is the ability to shift one's mental focus within a task, such as sorting by color versus sorting by number. So it's being able to shift the way you do things. Also seems to be an issue with ADHD. So within these areas, the areas that have been researched the most and have the most empirical support as far as differences between those with ADHD and those who do not have ADHD are spatial working memory and response inhibition. And all those have moderate to large effect size differences between, again, kids with ADHD and kids who do not have diagnoses of ADHD. So there's evidence primarily of dopamine and norepinephrine being the most important transmitters as far as difficulties with ADHD. There is some evidence of epinephrine and serotonin, but for the purposes of our class, no dopamine and norepinephrine. Those seem to be the big two. So we've tried to treat ADHD since the 1930s, and early on we used amphetamines, which are stimulants, as you know from previous lectures, in order to treat ADHD. And it's interesting because some of our treatments, as we'll discuss, are actually still amphetamines. So while a lot has changed, actually a lot has stayed the same in the treatment of ADHD. In 1955, Ritalin, or methylphenidate, was introduced in the U.S. and is approved for use in kids in 1961. Now, what's amazing, you may hear of a lot of different medications with different names, but as we'll go over today, a lot of these drugs are actually methylphenidate, just prepared in different ways. So this is still the drug that's by far the most used for ADHD. Just been that way since the late 50s, early 60s. All that's different is the pharmacokinetics. Just changing the way the drug is prepared. So we'll get into much more on that. So what we have seen is over recent years, we have seen a large increase in ADHD diagnoses, unless we also have seen an increase in stimulant use. We've also seen a large increase in stimulants being abused. So we've already talked some about the abuse potential of stimulants, but also what you really have to understand is cognitively, stimulants are performance-enhancing drugs. These are drugs that if you give them to pretty much anyone, it's going to improve their performance, their ability to focus, to memorize things, remember things. It's going to be enhanced. So what you cannot do is you cannot just give a kid a stimulant to see if that helps, and if that helps, say, oh, they must have ADHD. You can't diagnose by prescribing the medication, because if you give these drugs to almost anyone, they're going to help. So with it, you really need a thorough evaluation in order to diagnose ADHD. You can't just prescribe and see what happens. So stimulant treatment is one of the most broadly effective drug therapies we have. Of course, it doesn't work for everyone, but it works for 60 to 80% of children with ADHD. And this is actually quite good when you look at the efficacy of many of our other treatments. So that's fantastic. Overall, though, stimulants do improve functioning and how well a student's able to focus and learn. But what you see is on the actual functional impairments, you don't see much of a change. So that's where, we'll talk about some of the guidelines with ADHD, but I think that's where behavioral therapies really could play a role, because stimulants do help a lot. And in a way, you could just do it with the stimulants, but I do think there are aspects that are improved with behavioral treatment enough to where I, as a clinician, would probably recommend both. But if you had to pick one, you pick stimulants. Stimulants are very, very good treatments for ADHD. So, a couple things that are important. Stimulants, ADHD in general, it's really only well studied in older children, adolescents, and adults. Younger children with ADHD, will treat it, but there's not a lot of research in preschool ADHD. We do know that it can present in preschool, though, and persist into adulthood, so it can develop that early. We just don't have much research on it that early. The symptoms do differ across the lifespan, so again, you really want to have a thorough psychological evaluation with testing in order to diagnose ADHD. It's not an easy diagnosis to make. Within ADHD, what we see across the lifespan as early as preschool is that those with ADHD do have very high comorbidities with other disorders, such as ODD, oppositional defiant disorder, conduct disorder, things of that nature. Sorry, I had someone knocked on my door there, but I think that pretty much wraps up the slide. It's just, again, it's a very difficult diagnosis to give, so with that, you really want to make sure that the individual has a thorough evaluation before giving this diagnosis or treating with medication. So, methylphenidate in preschoolers. So again, methylphenidate is the same as Ritalin. So this was first demonstrated in the PAT study, where they gave 14 milligrams per day immediate release dose in preschoolers, and what they found is that there were significant reductions in ADHD symptoms, though overall it wasn't as effective as it was for school-aged children. And with the study, a couple things. So what they did is, if the treatment was actually helpful, they discontinued the trial after 6 months to reassess the children. And then if it wasn't effective, then they would try an amphetamine such as Adderall. Even though there hasn't been many studies that have shown Adderall to be efficacious in young children. Additionally, whenever there isn't anything showing efficacy, there often isn't anything to show safety. So Adderall could be considered, but there's just a lot less research on preschoolers and Adderall than, for instance, methylphenidate and ADHD in children. So within school-age children, so a little bit older, there is this really great study that was the MTA Cooperative Group Study. There was a 14-month randomized clinical trial of different treatment strategies that we'll see on the next page, and they followed up with the children many different times, which has been a really nice way of looking at the effects of treatment over time. So this was a multi-center study of almost 600 children with ADHD who were treated within 4 different protocols. So the protocols were either medication management, which involved titration for daily administration, behavioral treatment only, a combination of medication and behavioral treatment, and then usual treatment, which is kind of standard community care for these kids. And what they found was that overall, carefully crafted medication management was actually superior to behavioral treatment as well as to routine community care. So the medication management did very well. Additionally, they found that combined treatment did not yield significantly greater benefits than medication management for those core ADHD symptoms. So things like inattention and irritability and impulsivity. For those symptoms, adding on behavioral treatment didn't really help. However, behavioral treatment may have positive outcomes in other ways. So, for instance, looking at combined treatment in comparison with just medication management, we do see better results for combined treatment in terms of parent and teacher satisfaction with treatment, having a more normalized child behavior, so having the child behave more in line with their peers, and also improvements in functional outcomes such as family interactions, peer relationships, and academic functioning. So even though you don't see a huge improvement in those core ADHD symptoms with behavior therapy, I'm of the mindset, because these are very important aspects of child development and of child functioning, that combined treatment is still indicated. As you'll see very soon, as far as the recommendations, I'm kind of out on an island with this, but I think it's valuable. But I'm also a psychologist, so I'm biased in that way. So again, one of the nice things about the MTA study is they follow it up several times looking at the effects on kids. So with the follow-up in 2004, they found that stopping drug therapy was associated with clinical deterioration. So you really have to keep taking the stimulants in order for them to be effective. It's not a short-time thing. Also, with it, continued drug therapy was associated with only mild deterioration. So people got better with the stimulants, and they did, the effects kind of waned a little bit. They were better, but not as good as they were at the very beginning of stimulant therapy. However, they were better than if they had pulled off the drug. And overall, they did see that continued stimulant use was important in maintaining effectiveness, but as you may have heard before, there is some growth suppression that you see with stimulants that was observed in the study. They then followed up with these students 8 years later, and they found that only a minority, only 33%, were still receiving medications, with most of these being stimulants. And even with this, even though improvements were seen, about 30% still met criteria for ADHD, even despite taking the stimulants. They also found very high rates of comorbidities, such as antisocial behavior, ODD, being arrested, and also having moderate to serious delinquent behavior. So a lot of those negative behavioral outcomes were really evident. Again, I think this is one of the reasons why it may make sense to incorporate combined treatment in order to improve social skills, have more normalized behavior that's consistent with peers, in order to hopefully try to avoid some of these negative outcomes. So, similarly, medicated children with ADHD overall showed an improvement over those that did not receive medication in both math and reading, but they still weren't as good as children that didn't have ADHD. So they were better than no treatment, but not all the way better. And as far as persistence, around 78% of participants made at least one definition of ADHD persistence. So this isn't going to fully treat the ADHD. There's still going to be deficits present even with medication treatment, stimulant treatment for ADHD. So what are the actual guidelines or the advice for practice? American Medical Association encourages the use of individualized therapeutic approaches, which may include pharmacotherapy, but also some of the behavioral interventions. So this is one of my favorite because I do like the emphasis on individualized medicine. It's something you absolutely can do with ADHD because if done well, ADHD is going to first start out with a very thorough psychological evaluation and educational evaluation. So you're going to very clearly know the deficits that the child is exhibiting, and then you can target the intervention where if it's just purely the core symptoms and they're not showing any problems with relationships or acting differently than their peers, then maybe you just do medication. But if they're having trouble with those core symptoms and they're having problems with peers or they're not fitting in school, they have some behavioral issues, then maybe a behavioral intervention or some other type of intervention may make some sense. American Academy of Pediatrics advises that a clinician should recommend medication and or behavior therapy, but they state that the evidence for medication is stronger. Now, again, I think this is accurate if you're looking at the core symptoms of ADHD. Without a doubt, the evidence is stronger for the medication for those core symptoms. However, for the other outcomes, I do think that behavior therapy has very strong evidence. And then lastly, the American Academy of Child and Adolescent Psychiatry essentially says that pharmacological drugs are more effective than behavioral, and just consider the behavioral interventions if the medications don't work. Not my favorite guideline, but, what can you say? At this point, you've already made up your mind on what you think someone should do as far as treating ADHD. But it's something to think about as far as, should you just do the medication and not worry about anything more? Is the benefit you get from therapy worth the cost of therapy? Therapy can be expensive, especially if it's not in a training clinic, or if you don't have insurance. So you have to also look at the cost benefit of therapy, asking, does it contribute enough to actually be worthwhile above and beyond the effects of the medication? So one of the worries that people always have is you're giving children these medications that are abused, so are we going to increase the likelihood that they will abuse medications in the future? And what we see is no, that's not the case. If you don't treat ADHD, and you have comorbid disorders, those children are at increased risk of substance use. However, children and adolescents that use stimulants for ADHD appropriately, they have the diagnosis, they take the medications as prescribed. That's not associated with later substance use. And if anything, it seems to make later substance use less likely. So, you don't need to worry about whether or not to treat because you're worried about future substance use. If the treatment is appropriate and the diagnosis is accurate, if anything, you're going to be reducing the risk of future substance use. Diversion of stimulants is a really big problem. Especially, it seems to be a really big problem in colleges, actually. You see it all the time. So the rates of non-prescribed stimulant use in grade school and high school are as high as 5 to 9%. And the range is 5 to 35%, huge range. But a large number of college students are using stimulants inappropriately, whether it's selling them, sharing them with friends, or taking them when you don't have a diagnosis for which they're indicated. And the reason why is I mentioned that these are performance-enhancing drugs. Performance-enhancing drugs are not just for athletes. These are the ones for the rest of us. So they do help with alertness and concentration, and they can be used to get high. But often in college, they're used when someone's cramming for something. So with this, it's really important to educate those who have ADHD and have medications about the pitfalls of misuse and diversion, and also the potential consequences, especially with amphetamines such as Adderall, which are dangerous drugs if used inappropriately. So, methylphenidate, Ritalin, is 90% of all ADHD medication. As I described, there are a lot of drugs out there that go by a lot of different names, but really, most of them are actually just different ways of packaging Ritalin. So the reason why you have so many packaging differences is the main problem with Ritalin. The good thing is it's a very rapid onset, or fairly rapid onset. About a half hour you're going to start seeing some effect of the Ritalin. But it has a short half-life, so children taking Ritalin may have to take the medication several times during the day in order to get through a whole school day. So, that's problematic. That may not work with the school schedule, the child's schedule. It may lead to adherence problems. So with that, again, there are multiple dosages and delivery forms to try to address that, and we'll talk about those as we go through. So what methylphenidate does is it increases the dopamine in the synaptic cleft by blocking this presynaptic dopamine transporter. So it blocks reuptake. It's much like what an SSRI does, but with dopamine. So with this, it goes back to that original hypothesis of that dopamine may be one of the primary chemicals that's underactive in ADHD. So with that, if we are able to increase dopamine to appropriate levels, we should see an improvement in ADHD symptoms. But again, the problem with methylphenidate is it has a very short half-life, so you need to administer it several times a day. They do have a sustained release version of Ritalin called Ritalin SR. But the problem with sustained release is it's a slow release. So while Ritalin has a fairly fast effect, 30 minutes, 30 minutes, hour, you just start seeing an effect. This sustained release is a very slow onset of action. It's going to take a while to actually get up to blood levels to where it's going to be effective. Once it gets there, it will last for about 6 to 8 hours, but it's hard to predict the response, and the response does seem to be variable. So this is not the best option for many people. Now there's Concerta. I actually like this solution. So this is, again, a methylphenidate concoction where there's a layer that's an immediate release, so you have some of it where it's immediately released, so you get the immediate benefit of it. And then you have this osmotic pump that gradually releases the methylphenidate over a 10-hour period. So you kind of have the initial burst, and you have that sustained release throughout the day. The main thing that sometimes grosses people out is the tablet actually remains intact. So you will excrete the shell. So again, these are just a bunch of different ways that you can formulate Ritalin, just different ways. So we talked about Ritalin SR a little bit. So what these methods are doing is they actually have a wax preparation that makes it so the body can't absorb the medication as quickly. So the release isn't as reliable or as consistent as other medications, but it's a lot slower than just giving pure Ritalin. Again, I kind of like these double post strategies where you have a bimodal release, you have an immediate release, and then you have a delayed release. And they're different medications that are sold under different names that again they're just Ritalin. That's all they are. It's just different ways of mixing this up. So if you have Focalin, this is half immediate release versus half being delayed release, whereas Metadate CD is 30% immediate release and 70% delayed release. So just different ways of doing the same thing with the same drug. One of the options I like best, honestly, is transdermal patch. So this patch you put on once a day. The problem is it takes 2 hours to take effect. So you're going to need to put on this patch pretty much right when you wake up. And it can be used for a maximum of 9 hours. The problem here is if you wear it for more than 9 hours, the effects will last for another 3 hours. So you're going to need to put this patch on right when you wake up and take it off at least 3 hours before you want to go to bed. But the nice thing with any transdermal patch is it's going to give you a very steady, reliable dose of the drug throughout the day. And what was found is that in a 4-week study of children that received oral methylphenidate and switched to the patch, they overall found an improvement in ADHD behavior and quality of life. This made some sense because they're not constantly going up and down where the med's going into their body, then they're having the symptoms of it going out of their body. It's just a very steady dosing of the medication. Also, caregivers liked it because improved behavior and there's less worry about missed doses because you're good for the day. You slap it on, good for the day. Amphetamines have also been used for ADHD. We mentioned that going back to 1937, they've been used. And when you look at Adderall, it's really kind of a similar concoction to what was used way back in 1937. There's also Vyvanse, and we'll talk a little bit about it. So with amphetamines, they have longer half-lives than methylphenidate. So with this, the half-lives are about 5 to 6 hours. So you don't have quite the dosing issues that you have with methylphenidate. So Vyvanse is an inactive prodrug. Well, you'll remember what a prodrug is that's a drug where the initial chemical concoction is not psychoactive, but it's metabolized into something that is. So codeine is a prodrug, remembering back to a couple of weeks ago. So same thing here, the actual drug is not psychoactive, but when it's broken down, it does become psychoactive. So with that, the breakdown takes some time. It's not an all-at-once thing. So that kind of helps more of a gradual release of the drug into the body. The other nice thing with Vyvanse is the breakdown is actually a lot slower if it's injected or snorted. So with it not having the initial drug be psychoactive, there's a less of an abuse potential because the body has to break it down for it to take an effect. So you can't just inject this or snort it and get high because, again, it's not in an active state initially. So comparing methylphenidate to Adderall, once daily Adderall appears to be about similar as far as efficacy to twice daily methylphenidate. Some studies have even shown it to be superior, but it's probably pretty consistent or similar. Head-to-head comparisons between Concerta and Adderall haven't been done as of yet. So there are some other medications you can use for ADHD, and these you may use for the 10 to 30% of kids that don't respond well, or you may have some kids where the parents would rather not use stimulants. And there are a lot of reasons why you may not want to. So look at some of the side effects of stimulants. Insomnia makes sense because it is a stimulant. Same with elevated blood pressure and heart rate, reduced appetite. But again, the growth suppression seems to be one that really gets a lot of parents and people worry about. But overall, these are manageable side effects if the drug is taken properly as prescribed. As far as some potential side effects, but not common ones, you can have new or worsening behavior, bipolar, aggressiveness, hostility, and psychiatric symptoms such as hearing voices, delusions, etc. It didn't make sense. These medications are increasing dopamine, so given your dopamine hypothesis of schizophrenia, this makes some sense. You may see things that look kind of like schizophrenia potentially. Then you also can have cardiac safety and sudden death. So with this, the FDA wants not to use stimulants in children or adolescents that have known serious heart problems. So again, some of the limitations of stimulant treatment doesn't work for everybody, but honestly, 80% is very good compared to a lot of the medications we've talked about this semester. It has limited impact on the domains of functional impairment. And so with it, it's improving those main ADHD symptoms, but maybe it's the relationships with others or the child's behavioral issues that are really the reason why the parent is seeking treatment. Well, the medication's not as likely to affect those or help those. So again, that's where combination therapy with psychotherapy probably makes a lot of sense. It's not going to normalize behavior. It's not going to be as if the child doesn't have ADHD, but it is going to result in significant improvements compared to other children who are not being treated for their ADHD. But there may be problems beyond the scope of medication that treatment, especially psychotherapy, would really be beneficial for. These medications have been used since the 50s, so, we know a fair amount about their use long-term, but there haven't been a lot of long-term studies to fully assess their efficacy and their safety. So, one option that's, again, not a stimulant is Strattera. So this was approved in 2003, and the approval was expanded in 2008. This is an SNRI, so it's a selective norepinephrine inhibitor, a reuptake inhibitor. So again, the thought is norepinephrine and dopamine both seem to be associated with ADHD, so maybe if we increase the norepinephrine by blocking the reuptake, again, similar to what an SSRI does with serotonin, would that improve ADHD? And the answer is yes and no. Overall, it is an effective treatment, but it's more effective in those who are treatment naive than in patients that have previously been treated with stimulants. So if this is a medication you want to try, ideally you want to try this before ever prescribing stimulants, or else you're going to not ever be able to see the full benefit of this medication. There are also a couple drugs that are antihypertensive drugs that are dopamine agonists. So again, they're going to increase the dopamine effect in the brain, which makes sense given our theory that ADHD may be due to a dopamine impairment. So they have been shown to increase dopamine in the prefrontal cortex, which is the area we discussed as being really important for a lot of the symptoms of ADHD. The problem with both of them is they have sedation and fatigue as very common side effects. So the longer you are able to stick with treatment... Oops. Sorry about that. Siri decided to interrupt the lecture. I will unplug her now. So anyway, the longer that you stick with treatment, the less that the sedation will affect you. So you kind of become tolerant to that side effect, but it is something that you have to deal with initially. There's also evidence that if you combine these treatments with stimulants, that you see a greater improvement for ADHD than with either drug alone. So it may be a really nice supplementing medication. And then we just give antidepressants for everything. So fluoxetine, aka Prozac, or Buspirone, there are some initial reports indicating that they may be useful. They don't really, Prozac doesn't fit into our theories as far as it's not going to help with norepinephrine, it's not going to help with dopamine, but maybe it helps with some of the other behavioral issues. Maybe some of the other behavioral issues are more serotonergic, mood related, and it could potentially be helpful there. Now, Boost Bar, remember, Boost Bar is Wellbutrin, which does increase dopamine. So it actually made some sense there. And it has been reported to be effective in adults and adolescents with ADHD that are comorbid with other disorders such as depression or substance use.